side waiting to come in. We do have just a few seats left. Also, a quick program note, we are here to talk about breast and cancer today. So if you're here to see Sleeping Beauty, it's not a fairy tale today, okay? We're talking reality. Good morning, my name is Heather Quarterman. I am from the Hometown Morning Show on 92.1 KKDV. Thank you so much for attending today's Many Faces of Breast Cancer. On behalf of Diablo Valley Oncology and Hematology Medical Group, the American Cancer Society, the Cancer Support Community, and AstraZeneca, it is my honor to welcome you all here today. It is an interesting thing to talk about cancer. Not a lot of people like to mention the big C word, but it's something that affects so many people in so many different ways. I am no exception to it. My aunt was actually diagnosed with cancer when I was in high school. And when you're a teenager, it's pretty hard to watch somebody lose their hair, go through chemotherapy and radiation, and watch them put their wig on for the first time. But for the last 10 years, she has been cancer-free. And that is what we're going to talk about today. Thanks to early detection, science and treatment advances, and patient empowerment, more women are surviving breast cancer than ever before, and we are here to celebrate the 2.5 million breast cancer survivors here in the United States today. They serve as a visible and vocal reminder that life does continue after diagnosis and treatment, and we're also here to discuss the unique issues that affect breast cancer survivors, the issues that you face after you've completed primary treatment. We're also going to discuss the latest data surrounding treatment and exploring key survivorship issues, like the risk of recurrence and staying on track with your treatment. I'm also excited to welcome some very special guests this morning. We have a great panel of leading medical experts from Diablo Valley Oncology. I'd like to present Dr. Tiffany Svahn, a medical oncologist and breast specialist, breast cancer specialist. Sitting next to her is Dr. Sandy Altman. She is a local gynecologist and menopause specialist. Who is a cancer nutrition specialist. And in case you're wondering who the fabulous lady on the end is, her name is Radhika Gupta, and she is a breast cancer survivor. All together, they're going to discuss some of the medical, physiosocial, and nutritional issues that face breast cancer survivors today, and we are also going to hear about a personal story of survival. If you wouldn't mind holding your questions until after all of the panelists speak, inside your bag you've received sheets that look like this. And at the end of our discussion today, they'll be answering some of your questions. So at any time, if you think of something that you'd like to ask one of the doctors, please write their names, Dr. Altman, Dr. Svahn, Tinrin, Radhika, on the top of this, and they will be passed along and we'll answer your questions accordingly. Also in your program folder, pretty black bags that you all received, you're also going to see some short surveys. Of course, your feedback is so important to all of us, and at the end of the program, if you would, just take a couple of minutes to fill out the form, and we'll collect them as you leave today. Good morning, welcome. How are you? Don't feel bad if you have to cross the podium today. I understand there are a lot of people here. We do have a couple of seats left, so just come on in. It's no big deal. We're all like family today. At this time, I'm pleased to introduce Margaret Stauffer from the Cancer Support Community, San Francisco East Bay. She's a huge supporter of cancer patients and a co-sponsor of this event.
Heather. For those of you who may not have gotten any information from us lately, but know the wellness community, that's what we used to be. We recently changed our name because we merged with another cancer support organization called Hildis Club. So now there are 50 cancer support communities across the country to provide hope, education, and support for people with cancer and their families. I recognize many of you, and I know you've been to our community, but for those who are new, I would just like to tell you a little bit about some of the services we provide specifically for people living with breast cancer. We have a newly diagnosed breast cancer series. That's a 16-week program that includes speakers on topics that are relevant to people going through breast cancer treatment, and also provides support and encouragement for people who know what it's like to be going through this. In addition, we have a twice-a-month Breast Cancer Networking Group. That's a drop-in group. You can come when you feel like it, connect with people who may be farther along the journey, and another great way to get support, get information, share with each other. We have a wide variety of programs that are helpful to people post-treatment. Things like yoga, qigong, Feldenkrais awareness through movement. All of those things help to regain function, strength, flexibility, and we encourage you to access those. We have a number of nutrition programs, including wonderful programs with Tinrin, provide an opportunity to get more information about the role of nutrition when one is in treatment and beyond treatment. We have lots of fun activities too. We really are a community, and it's a place to be with other people who know exactly what it's like. So we encourage you to come meet with us, see what it feels like to you, get that sense of being supported by others who have been on that journey, both for the person with cancer and for their loved ones. So thank you.
It's kind of tough being tall in heels. Thank you so much, Margaret. We are also privileged to be joined by Julianne Lee of the American Cancer Society Greater Bay Area and Redwood Empire region. She's going to share some of the resources and services that ACS provides here in our community.
Good morning, my name is Julianne Lee, and I'm the Health Programs Manager with the American Cancer Society. Thank you so much for joining us today, and a special thanks to Diablo Valley Oncology, the whole team, Sandy Goldberg, for organizing this event and allowing us to take part in it. I wanted to start off by sharing a bit about myself, if I may. My work in patient advocacy began after my own experience with the disease. In 1988, I received my diagnosis, and as of this year, I am now 22 years post-bone marrow transplant. I can certainly attest, speaking from my own experience, of course, that information and resources were vital in my recovery, thus my interest in the field. Now, when I joined ACS 6 years ago, I had been working in nonprofit for many years, but it was the first time I understood the term voluntary organization. I want to share my favorite factoid about the organization. In our California division alone, we have about 600 paid staff like myself, full-time and part-time, and get this, over 200,000 volunteers. And that is the reason that we can provide our services free of charge. Now, I want to talk about Reach to Recovery. I don't know if you're familiar with it, but we provide peer-to-peer support, one-on-one peer-to-peer support for newly diagnosed breast cancer patients or patients who are looking at new treatment options. We have volunteers in the community who are certified by ACS to provide one-on-one support to those who are more newly diagnosed. So if you're interested in that, contact our National Cancer Information Center. We have a 24-hour information line based in Texas. And we really see this service as a way of assisting patients by doing the prep work with you before you meet with your medical team. So our specialists are bilingual Spanish-English, and callers who speak other languages may also be assisted via translation line. They can go over basic information such as test results. They can help you understand blood results. We of course do not give medical advice, but again, so as to maximize your time at your next appointment, we can go over the basic questions with you. I also want to mention transportation assistance for patients. The Society, we provide transportation assistance in a number of ways. First of all, for patients in financial need, we provide up to $300 in gas cards per year, per fiscal year. We also have volunteer drivers in the community who will drive patients to and from their medical appointments. And finally, we provide paratransit vouchers free of charge. So the bottom line is that patients in treatment will not have to pay for the transportation costs. So keep that in mind, and let's see, Look Good, Feel Better. One of our volunteer cosmetologists, Chris Nelson, is here. This is a wonderful program that DVO and many facilities host. What it is we have volunteer beauty professionals who donate their time to teach a class called Look Good, Feel Better. They give women in active cancer treatment tips on skincare, nail care, and the aha moment of any Look Good, Feel Better session is when they teach women to take any t-shirt and cut it in a certain way and make a t-shirt wrap. It's a head wrap. So that's a fabulous program, and again, it's free of charge. And because we partner with Cosmetology Association, each attendee receives a makeup kit valued at over $350. I attend as many of the sessions as I can. I tell you, it is so much fun. And my theory is that you put women and makeup in a room together, and it is definitely the lighter side of the cancer journey. So I encourage you all to check it out. And again, go by the information table. We have information there for both organizations, and we encourage you to research a bit and find out about our resources. Thank you so much.
Thanks, Julianne. Well, from support services to modern medicine, next I would like to introduce Dr. Tiffany Svan. Dr. Svan is a medical oncologist and breast cancer specialist with Diablo Valley Oncology Hematology.
Thanks, Heather, and thank you to all of you for coming this morning. I have to say that it's truly a pleasure and a privilege to be able to be surrounded by this room full of breast cancer survivors and all of your loved ones. And we're all here today to celebrate survivorship, so thanks for joining us. And I'd like to thank the American Cancer Society, the wellness community, and AstraZeneca on behalf of Diablo Valley Oncology for partnering with us to do this again. We did this last year. It was the first one in the East Bay, and it was so successful and well received that we really wanted to do it again. So thank you guys, and thank you to Heather Quarterman for being our moderator with her very upbeat spirit. And then I'd like to give a very special thank you to Sandy Goldberg from our practice. She's our outreach manager at Diablo Valley Oncology. She did this. And she designed the pretty little bags. Okay, so this is October, right? So this is Breast Cancer Awareness Month, and we can't walk down the street without seeing 10 pink ribbons. And it's fantastic. It's fantastic that we are involved and either suffering from or have gone through treatment for a disease that has so much public awareness. And that awareness leads to fundraising efforts that raise millions and millions of dollars, maybe more. And that's what leads to our research and our improvements in screening and treatment for women with breast cancer. So you all know how important this disease is. You know that it is the most common cancer in women. You also know that it's one of the most common causes of cancer death in women, second only to lung cancer. And in 2009, there were more than 194,000 women diagnosed with breast cancer in the United States. This is an astounding number, and it goes up a little bit every year. But despite that, the mortality, the death rate from breast cancer goes down every year. And that is because we have such wonderful screening programs to be able to pick up breast cancers when they're early and curable, but also because we have some fantastic treatments, and the treatments advance every single year, allowing women to be cured from this disease. And if they're not cured and they do have to live with advanced breast cancer, they live longer and they live with better quality of life. So that's what we're here to talk about today. And we heard the statistic that there are more than 2.5 million breast cancer survivors in this country. And you guys are part of that group, so congratulations. So what I'd like to start with is a definition of what is a cancer survivor. And I had a definition from last year, and I did some Googling, and I found some other definitions, so I made my own. I put a few together, and this is what I like to think of as a cancer survivor. A cancer survivor is an individual is considered a cancer survivor from the time of diagnosis through the remainder of life, whether that is days or decades. Family members, friends, and caregivers are also impacted by their survivorship experience and are therefore included in this definition. And that's really what I added this year, is that I really think it's important to acknowledge the people who have helped you through your journey. And I know you all do that on a personal level, but we as a medical community really do acknowledge the support and what is involved in helping someone get through treatment for breast cancer. And I know many of you are out there in the audience, so thank you also for joining us. So when I think about breast cancer survivors, I think that there are two types of survivors. There are women who have had early stage breast cancer, meaning that breast cancer was picked up at a point where it was confined to the breast or the lymph nodes, and it's curable. And these women go through an acute phase of treatment of surgery, possibly radiation, possibly chemotherapy, possibly hormonal therapy, with the hope of curing the disease. And they become survivors as soon as they're diagnosed, but a lot of the survivorship issues come up when the acute phase of treatment is over. And so I really think of that as one type of breast cancer survivor. The other breast cancer survivor is one who has advanced breast cancer, and their breast cancer was not cured, and they are living with the disease. But as I mentioned earlier, these women can live for a long time because our treatments are so fantastic. And so these women are trying to live normal lives as much as possible, and they are breast cancer survivors as well. And so while the focus of this program is really on the early stage breast cancer survivor, a lot of the issues we talk about do really affect women who are living with breast cancer every day and being treated for breast cancer for the remainder of their life. So I'd like to acknowledge that as well. So we have 3 different phases or parts of breast cancer treatment. The way we like to think of it from the medical standpoint is there's the local treatment of breast cancer, which includes radiation and surgery, and then there is the systemic treatment, which is chemotherapies, hormonal therapies, and now what we call targeted therapies. And increasingly, the focus of these treatments, of course, is to improve life, quality, but quality of life has become very important. So as you look at the evolution of surgery and radiation, for instance, things have moved towards trying to make quality of life better because women are living longer with this disease. So we need to think about what's going to happen down the line. It's not just about treating the cancer, it's about treating the whole person and looking ahead. So when you go back decades, we all know that the treatment for breast cancer used to be radical mastectomies. The entire breast came off, the pectoral muscle came off, it was a deforming surgery, and things have come such a long way. You know, still women do require mastectomies at times, but when we can, we try to do breast preservation. So we really, if a woman is interested, we can conserve the breast in many cases, meaning that we just remove the tumor and some surrounding normal tissue around it, but leave most of the breast intact, and then use radiation treatment to try to sterilize or remove any other disease that might be left microscopically in the breast. So when possible, that is one of the treatment goals from the local treatment perspective. And that does improve quality of life. And that improves cosmesis, cosmetic outcomes, and it improves how women feel in many cases. So that's something that's evolved over the past few decades. Along the lines of surgery, in the past, we all know that lymph nodes under the arm, under the axilla, have to be evaluated for breast cancer to see if the cancer has spread to the lymph nodes. In the past, all the lymph nodes, or majority of lymph nodes, were removed, and that is called an axillary lymph node dissection. And that can leave women with lymphedema, which is something that I'm sure many of you in the audience have to some degree. And now we have, when we can, moved away from completing an axillary dissection. So we try not to take out as many lymph nodes, if possible, by a procedure called a sentinel lymph node biopsy. So sentinel lymph node biopsies are when the surgeons take out somewhere between 1 to 4 lymph nodes. And if those lymph nodes are clear, the rest of the lymph nodes can stay in the body. If those lymph nodes do have cancer, then we do have to go on and take out the rest of the lymph nodes. But that does spare a lot of women from having to lose all their lymph nodes and put them at risk for lymphedema. So that's another part of how we're trying to improve the long-term quality of life of women with breast cancer. And then with radiation, the standard treatment for radiation is radiating the whole breast, and that is still the standard treatment. But there is now a form of radiation evolving, which is now approved for women in certain categories, which is called accelerated partial breast irradiation. And in this case, instead of 6 weeks of whole breast radiation, women can have 5 days of radiation just to the part of the breast where the tumor was. So this is not for everyone, but this is an option that's out there, and it's been studied for a while and really becoming increasingly available to women. So again, coming back to that idea of let's do as little treatment as we can to get the best results, but with the best quality of life. So that's the local treatment. And now let's talk about systemic treatment, and that's what I do. I'm a medical oncologist. And systemic treatment consists of possibly chemotherapy, hormonal therapy, which is a bit of a misnomer because it's actually anti-hormonal therapy, as many of you know, and then targeted therapy. So chemotherapy affects the whole body. And there are many women who need chemotherapy for breast cancer. And breast cancer, chemotherapy is still a very, very important part of breast cancer treatment. But when possible, if we can avoid chemotherapy by using hormonal therapy, which is a form of targeted therapy, we try to do that. And so in certain circumstances, if a disease is not too advanced at the beginning, or if it's responsive to hormonal treatment, we will try to use that, and that improves quality of life without having to use chemotherapy. And now we live in the decade of targeted agents, which are fantastic, and they're really changing the whole frontier of cancer treatment, where we have drugs that are available that really target the cancer cells and not affect the rest of the body as significantly as chemotherapy does. So many of you are familiar with the drug Herceptin, and Herceptin is used for women who have HER2-positive breast cancer. That's about 25% of breast cancers, and that is a drug that targets the cancer cells themselves. And that is the most commonly used targeted agent in breast cancer treatment in early stage disease. And then we have some other drugs that are being used in advanced cancers. Avastin is a wonderful drug, and another drug called lapatinib or Tykerb. And there are many, many, many more targeted treatments that are available, or becoming available. They're in clinical trials now, and so we will be seeing more and more of these targeted agents as we move forward. So what I want to talk about with survivorship issues is a few different things. So when a woman finishes her, what I think of as the acute phase of treatment, which is a chemotherapy, potentially surgery, radiation, and during that time they're coming to the office once a day for radiation, once a week, every other week, every 3 weeks for chemo, and they're there and they're with us and they feel good about the fact that they're with us, and all of a sudden, at the end of treatment, we say, okay, we'll see you in 3 months. And that is, I think, across the board, a very anxiety-provoking time for women. All of a sudden, they're not being watched closely, and they're not actively doing treatment. Now, many women will go on to hormonal treatment, which is oral medication, but they're not coming in for treatments, and they start to feel a little bit worried. So I always make sure to reassure my patients at that point that they can call us at any time. They can come back sooner. But what's even more important at that phase is to make sure we make the appropriate referrals to other healthcare team members. So at this point, it's very important to make sure that if the primary care physician or the gynecologist has been a bit out of the loop during treatment, which does happen when things are busy with chemo and radiation, we make sure we get our patients back to their primary care physicians and their gynecologists and all their other physicians and start to get back into a phase of normalcy with their other medical issues, or just helping with the primary care, helping to follow them and helping to reassure them. And so we try to, I know I write letters to my patients' primary care physicians and say, this is what's happened, this is where we are, and if you can help us be part of the team again to help follow these patients, that's very important. Other important issues of survivorship that we need to identify at that point are symptoms that patients are dealing with as they finish their treatment. So women will have pain, they will have fatigue, they will have deconditioning, they will have possibly gained weight, they will have had hair loss, and all of these things are going to be ongoing issues that aren't going to resolve overnight, and we need to recognize that and make sure we're helping them deal with all of those issues. So we make sure that we refer patients to appropriate physical therapists if needed, occupational therapists, lymphedema specialists to deal with the arm swelling if that has been something that's come up. Psychosocial help, so we work with some psychiatrists and psychotherapists that we will make sure we'll get patients to. So this is really the phase where you can't just say, bye-bye, I'll see you in 3 months, but hey, we have all these other resources that we can help with. And this is also a time, if women have not been involved with the American Cancer Society or the wellness community, or if John Muir patients, the Women's Health Center, to get them plugged into that. John Muir is developing a survivorship program. We heard about the wellness community, American Cancer Society, having programs to help you get back to life and help you get back to what you felt like before. And it's not going to happen overnight, but the more that we can support that change, the better. So that's a really important thing, I think, to stress to women. Another thing that we will talk about as we begin that every 3-month, every 4-month, every 6-month follow-up is what are the side effects that we're experiencing specifically, and what can we help you with? And Dr. Altman's going to spend a majority of her time talking about menopausal symptoms, because that is such a common group of symptoms that breast cancer survivors have to deal with. So we know that we put many women into an early menopause with our treatments, or we accelerate their menopause, or if they're already in menopause, we can make their symptoms worse, potentially by giving them the hormonal treatments that we give them. So I'm going to leave Dr. Altman to talk about a lot of the treatment options that we have to help with menopausal symptoms, which are significant and really impact quality of life. Fatigue, insomnia are very common complaints that women have. Weight gain, mood symptoms, and I talked about referrals to psychiatrists, psychotherapists, hair loss, and just feeling generally deconditioned. And then, of course, there's pain. So some women have pain, either from treatment. Chemotherapy itself can cause stiffness, achiness for several weeks to months after the completion of chemotherapy. Some women experience what we call neuropathy, which is numbness and tingling in hands and feet, which can occur from some of the chemotherapies that we give. And then the aromatase inhibitors, which are one of the widely used types of hormonal treatments, can cause joint pains, and these can be sometimes severe pains. So a lot of what we focus on in the follow-up visits when we're seeing our patients is helping them manage these symptoms. These aren't the acute symptoms of their treatment. These are chronic symptoms that are hopefully slowly improving over time, but they are very real, and they are very much a part of quality of life. And so I know in my day, I spend a lot of time talking about these issues with my patients. The other thing that is really important now to talk about is really lifestyle changes, modifications that we can do both to lead a healthier life in general, but also to decrease breast cancer recurrence and decrease progression of breast cancer in women who have advanced breast cancer. So we place a lot of focus on making sure we talk to women about exercise and diet. And Tinrun will be speaking about nutrition, which is so important. And we don't have an exercise segment this year, we did have one last year, but we talk about the fact that we know from studies that exercising 3 hours a week at least, coupled with a healthy diet, decreases recurrence of breast cancer by 50%, which is humongous. I mean, that's as much benefit as we get from the hormonal therapy, and in some cases more benefit than we get from chemotherapy. Not to mention the fact that exercising just makes you feel good. Makes you feel better, stronger, back to your normal self. So we try to help encourage women to exercise. We give suggestions about exercise programs, and at the end we're going to have a slide about some of the different areas you can pursue. The wellness community has wonderful exercise programs, as Margaret mentioned, and a really nice way to get started if you haven't been exercising. I just learned this week about Pink Ribbon Pilates, which I guess is out there, which is about half a drink a day. And this study showed that women who drank that much did better than women who drank more, and also did better than women who drank less. And that included women who died from other causes. So, not that I'm telling you all to go out and start drinking if you don't, but the reason for that is that there is some heart benefit to alcohol. And so women who don't drink at all do lose a little bit of the cardioprotective benefit of alcohol. So this study very nicely outlined that the threshold where breast cancer risk and benefit to the heart meet is at half a drink a day. So that's something that we can now actually give you as information. I think Sandy and Tim are both going to talk about that a little bit more as well. One last thing I'm going to talk about, because I think my time's probably way up, is bone health. And you may get a little bit more from the other speakers as well. But bone health, meaning the risk of osteopenia and osteoporosis or bone loss, is so important in breast cancer survivors. Women who are going into menopause anyway have increased risk of bone loss, but a lot of our treatments, most of our treatments, can actually affect bone strength. And so when we put a woman into an early menopause, or just chemotherapy in itself, or the anti-estrogen treatments, aromatase inhibitors can cause bone loss. So as medical oncologists, we now know a lot about bone loss, and we know how to interpret bone density tests, and it's something on my checklist to make sure my patients are getting their bone density tests. And if there is bone loss, we treat it aggressively with a class of drugs called bisphosphonates. And that is Fosamax, Actonel, Boniva, are the oral forms of bisphosphonates. And then there's Zometa and Iridia, which are intravenous forms. And they're very effective at building healthy bone. Well, what's exciting about it is this class of drugs, and I talked quite a bit about this last year, this class of drugs is emerging as an anti-cancer class of drugs. So we have more and more information that these drugs actually help reduce the risk of breast cancer recurrence in the entire body, not just in the bones. And in women who are living with advanced breast cancer, it actually has anti-cancer properties against breast cancer that's active in their bodies. So these are great drugs. They're not without side effects, but this is something that becomes a part of breast cancer treatment. So I think at that point I'm going to stop. I could talk for many, many more hours, but I'll stop, turn it over, and then we'll talk more because we'll have a nice long question and answer session at the end. Thank you.
Thank you, Dr. Spahn. Suddenly I don't feel so guilty about that glass of wine at the end of the day. I don't know about you. Or half a glass, I'm sorry, half a glass. Maybe 3/4. Remember, if you do have any questions for Dr. Svan, these pink sheets are for your use, and we will collect those throughout the session, and she'll review them at the end. Next up, I would love to introduce Dr. Sandy Altman. Dr. Altman is a gynecologist who specializes in sexuality and menopausal issues.
Thank you. I'm always very honored when I'm asked to speak to this group, or any group of breast cancer patients, so thank you all for inviting me. Let me tell you a little bit about why this is such an important part of what I do. When I was 8 years old and my mother was 32, she was diagnosed with breast cancer. That was a long time. My mother now, by the way, is 82. So I told others I thought breast cancer is a survivable disease, and that's just how I grew up. Now, for my mother, who did have a radical Halsted mastectomy, because she was so young, back then, and I have seen a few of these patients, Dr. Svan may have also, the incisions were vertical. Okay? Forget wearing this way. You wore turtlenecks and high neck because they went up to here. My mother was the first patient her doctor had ever done a horizontal incision on because she was so young. So I also grew up with the prosthesis and the bras and the trouble of finding clothing, and it has been thrilling to watch how much better the surgeries have become. And my mother is sort of ambidextrous. She had to learn to play tennis and golf with her other hand. So this is one of my tithings for what my mother has gone through. When my younger sister was 41, she was diagnosed with breast cancer. My younger sister is now 54. So this is something very personal to me, and that's why I want to do this. When my mother went through this, there was nothing available for her. Many years later, when Reach to Recovery existed, my mother was a volunteer for Reach to Recovery. So this has, again, been part of my life. About 10 years ago, the National Cancer Institute did a survey of what were the things that bothered women, particularly younger women, who had survived breast cancer. 97% said hot flashes, and 75% said vaginal dryness. So that's what I'm going to talk about. As Dr. Svan said, there's about 4 ways that women end up being bothered by these symptoms. 1, you're a young woman, my mother, you survived breast cancer. There was no chemotherapy then. There was no radiation then. She had surgery, and that was it. And then when she got to menopause and went through menopause and suffered with symptoms, she was just told you can't take estrogen. So that's one way that that happens. I wish I could give you all absolution for menopausal symptoms because you survived breast cancer. They took away my magic wand. I can't do it. The other way is you got through menopause. You're on your estrogen. You're a happy lady. Now they diagnose you with breast cancer. It's estrogen receptor positive. You have to stop your estrogen. And now you're symptomatic. I just had an 86-year-old patient who, bless her heart, was still using a little estrogen patch. And when they made her stop, she was in my office crying, "Oh, I don't want to live like this. The nice sweats, I'm soaking wet." So it can happen at any age. At 86, we make certain adjustments to how much we make people suffer. You live that long, you got to get some slack. Then there's a woman who went to menopause, she's fine, and then Dr. Svan gives her some of those lovely medications, particularly the aromatase inhibitors, that can give hot flashes to a male elephant. And then there's the woman who really suffers, and this is the younger woman, and this is 25% of breast cancer patients who was put into a chemotherapeutically induced menopause. And that's those symptoms are worse. It's right up there with what I get to do to women, which is a surgically induced menopause, because it's so abrupt. Your estrogen level is up here, and then it's dramatically lowered. You didn't have that opportunity to make some slower adjustments as you went through a natural menopause. Those women are terribly symptomatic, and those are the women that I'm often dealing with in my office. Now, if you are one of those women, what you need to know is just because you stopped having periods and started having symptoms, usually about your second cycle of chemotherapy, that doesn't mean you're fully menopausal. If you're under 40, 30 to 50% of women will stay menopausal. The rest, those ovaries bounce back. bless their little hearts. Now, that's on one hand maybe a good thing. On the other hand, because your symptoms will resolve. On the other hand, you gotta worry about birth control. You can't, and this is one of the things that kind of gets lost in the shuffle. What are you doing for birth control? And that's one of the first questions I ask. It's kind of not a bad time to kind of get your guy to have that vasectomy, if I'm promising you, because you're going through a lot. It's kind of the least you could do. And particularly if you're going to be on tamoxifen, because tamoxifen is related to a drug that I use to help women ovulate and get pregnant called Clomifene. In the names, you can hear the relationship. So unfortunately, we ovulate and then 2 weeks later get a period or not. So I have had patients who found out, not to their pleasure, that they were pregnant. So you do need to remember birth control. Even women over 40, which by the way is not so old anymore. Gets younger the older I get. Only 70 to 90% of those women will stay menopausal. So 30% of those women will end up rebounding and cycling again. So you need to bear that in mind, and you need to worry about birth control. John Travolta's wife, Kelly Preston, at 47, is pregnant. I'm not sure those are her eggs, but anyways. They don't say anything. If you read those articles, they don't say anything. So what makes us have a hot flash? Okay? Turns out, in our brain, we have something called the thermal neutral zone. Okay? So long as our temperature is in that zone, we neither shiver nor sweat. If our core temperature is above that zone, we sweat. Well, what happens is certain things, most dramatically losing our estrogen, makes that shrink. So we're at the same temperature, but now we're sweating. Other things that make that shrink, alcohol. You have a glass of alcohol at night, you're going to wake up with hot flashes. Okay? I mean, I'm sure some of you have experienced this. It will shrink that zone. Ambient room temperature. Okay, it's hot where you are. A stuffy room, getting upset, getting a surge of adrenaline. So one cure to not have hot flashes is to live in Alaska, don't drink, make sure nobody around you ever upsets you and never give a public speech. Then there are some of the more natural things like layered clothing. You know, you can wear wicking clothing, the kind of things you wear if you're a cross-country skier or a hiker that pull the moisture away from you. You know, start shopping in sports things. Cotton's not the best. Cotton will get soaked. There are wicking sheets that pull that moisture away from you, and jammies. So that's another thing that you can do. In your handout, I wrote a list of a variety of things. Vitamin E, not great, but for some women it helps. Hot flushes and flashes, 400 twice a day. You don't want more than that, you can begin to get some bruising. Black cohosh, Remifemin is the brand name that I know of. It's an over-the-counter product. It is not related to estrogen. It works probably in that central nervous system thing. Some studies say it's helpful, some studies say it's no better than placebo. By the way, placebos work very well. 30% of women get relief from their hot flashes. I would love to market and sell placebos. My experience, my feedback from patients is with the black cohosh, give it a month. If it works for you, it's going to work really well, and if not, it's not going to work at all. I mean, it really seems to be an either-or phenomenon. Other medications, there's all of the antidepressants, almost all of the antidepressants, have data that show that there's about a 50 to 70% reduction in hot flashes. Interestingly, it's at the lower doses. The first one we looked at was one called Effexor. Now I have to be bilingual. Venlafaxine is the generic name. I was never good with languages. 37.5 milligrams to 75. Zoloft, Celexa, citalopram. Its newer version, Lexapro. All of these work in their lower doses. When you get into the higher doses with these medications, there's no added benefit, and you get some of the more likely to get the sexual side effects. The two antidepressants that I don't recommend, one is Prozac, because people get head sweats. You know, already you're sweating, and that's the last thing you need under a wig is head sweats. And the other is Paxil. Now I learned not to like Paxil because Paxil, and here's the lovely euphemism, it's not weight neutral. Okay, you do not give an antidepressant to a woman that makes her gain weight, that makes her depressed. But the other thing with Paxil is it interferes with the activating metabolism of tamoxifen. okay? So you don't want it. I mean, and it makes you sleepy and it makes you gain weight. So given that there are other options, okay? The other drug that I've had really good luck with, and these are all, by the way, this is off-label, okay? It is not FDA approved to use an antidepressant to treat hot flashes. Doesn't mean that it's wrong, and it's not experimental because we have lots of studies that support that it works, okay? The difference between off-label and experimental is whether you're basing this on data and studies or whether you're just making it up. Like me saying, you know, eating 17 oranges a day will help you not have hot flashes. Okay, that's experimental. I just made that up. Don't do it. You'll have bad sores on your mouth from all that acid. The other drug is Neurontin or gabapentin. This is a central nervous system drug that's used for shingles, seizures, migraine headaches, and horrible nerve pain. Okay? For those doses, people take 800 milligrams 3 times a day. What I do with women is I use, and its main side effect is it makes you sleepy. So when I see a patient who can't sleep and is having night sweats, I go, I got a drug for you. And I learned that my patients are very sensitive. The lowest dose that comes says is 100 milligrams. I have people try that at bedtime, and they give it about 3 nights. And if you're not better, go up to 200 milligrams. Give it 3 nights. The drug comes as 100, 3, 4, 6, 8. So I started, use the once and then tell me what dose works for you. I've had really good luck with it, anywhere between 100 and 400. The downside is you try and take it other times of the day, it can make you sleepy. So you kind of play with it. Sometimes we do combinations. Effects are in the morning, Neurontin at bedtime. In a study comparing 800 of Neurontin 3 times a day to gold standard Premarin for hot flashes, identical results. So yeah, there are ways that we can do this. Maybe we don't get 100%, and even the estrogens don't always get 100% reduction of hot flashes, but we can really diminish them and make things more livable. There's other weird stuff that works. Clonidine, that's a blood pressure medicine. Belergal, which used to be available, now you have to have it made up, works for some women. Testosterone. I actually learned this from one of Dr. Swan's predecessors. But you can't use natural testosterone. Natural testosterone is aromatized to estrogen. For those people who are taking an aromatase inhibitor, that's what we're trying to prevent. But synthetic, I almost said unnatural, synthetic testosterones are not aromatized. And they actually can help hot flashes, vaginal dryness, mood, motivation, and of course libido. And they do some very interesting experiments to find out that it actually helps vaginal lubrication. So that's an option. They don't make testosterone, the synthetics, in doses that are appropriate for women. I've learned, when I first learned about this, I learned that it worked, and I taught the oncologist to drop its doses, and we got rid of some of the hair growth. So it has to be compounded for people. But the point is that there are options. In terms of the vaginal dryness, okay, it's not just vaginal dryness, and Dr. Swan asked me to bring my vagina with me, so I have the model that really shows that what happens, and it's on the bottom of your list. What happens is the bladder and the vagina are estrogen-dependent tissue. And what happens to the bladder is, without estrogen, it loses some elasticity. So you're full at a smaller volume, and when you gotta go, please everybody let that woman out of the room. She gotta go, okay? And there's lots of medications for that, but really estrogen helps that. And you can use vaginal estrogen to help that. And the reason that you can do that, because if my arm is my vagina and my hand is my bladder, the tissue in between it is not as thick as my jacket. So it's directly absorbed. Vaginally, yes, we lose lubrication, but the tissue becomes thinner, less elastic. The blood flow is less. Response becomes slower, muted. Sex isn't just dryness. You actually can get burning and tearing with this very delicate tissue. Lubricants are great, but sometimes all they do is make bad tissue slippery, and it doesn't help. And the pH changes, so you're more likely to end up with vaginal infections. Of the over-the-counter products, the 2 that I recommend to people, one is Replens and one is Refresh, with a pH, R-E-P-H-R-E-S-H. And I forgot to put those on the list, I apologize. They're made by the same company, and I can't tell the difference between them. ignore the directions, they say use it every 3 days. In a 7-day week, you wanna make yourself crazy, do something every 3 days. I tell people do it twice a week. Okay, before and after weekend, Monday, Thursday, Monday, Friday. What's counterintuitive with these products is you use them in the morning. They're a gel, they're supposed to adhere to the vaginal mucosa, and they draw fluid in, and so they make it a little bit thicker, a little bit more resilient, a little bit more elastic, and it also manages the pH. So you're less likely to get the yeast infections and bacterial vaginosis problems. Vaginal estrogens are available. Do not use the Premarin and Estrace creams. I can get somebody to have a fully therapeutic estrogen level using those creams. They are absorbed. There are 2 newer products that are out. One is called an S-ring, and that ring has 2 milligrams of estrogen in it, slowly released over 3 months. Daily doses of estrogen are 1 to 2 milligrams a day, okay? And then there are these vaginal tablets called Vagifem. Vagifem has just been reformulated. They dropped the dose by 60%. It has 10 micrograms in it. This can turn, well, my joke is if all I'm doing is, I do pap smears, if all I'm doing is looking at the vagina and the cervix, I can't tell you if she's 65 using Vagifem or 35 and it's her own estrogen. I mean, the stuff is good. If I had something that worked for our faces, we don't if you absorb, if you weren't listening to me and you didn't understand that I said you put the tablets in the vagina, even though it's on a little blue stick, and you thought, oh, I'm supposed to swallow it, and I'm supposed to save all my tablets for a year, put them in my hand and toss them back, you would get 1.14 milligrams of estrogen in a year. So I really think that this newer product opens avenues to address women's issues and their oncologist concerns about safety. You have to talk to your doctor about this. But you do have to make sure that they know that we've got newer products. And they've done the studies, we actually really have science. The estrogen levels that you have with the newer Vagifem is 9 the first day you take it because it's absorbed, that 1 day, 6 something by 2 weeks, and by 12 weeks it's about 4 to 5, which is the range that most oncologists want, even if you're on an aromatase inhibitor. What the standard line says, you can't use the stuff, but that goes back to when we used stuff that you really did absorb, and now we have new things. Another trick that you can do is you can get that tube of estrogen cream and you use a schmear, and I mean a schmear. You know the little dot that goes here, okay, for your eye stuff? That's how much you're using. And you can just rub it right at the opening because that's an area that becomes a little tight and can make sex impossible, and you use that a couple times a week. And that tube will last you more than a year. So it's, you know, we work around it, you use a lubricant, maybe a little bit of an estrogen cream, maybe the Replens. The goal that for me with patients is that quality of life thing. And using alternative ways around it to really try and help that woman have a decent quality of life. And you know something? Not sleeping is much worse than using sleeping pills, by the way. Particularly if you drive in Mullen Creek where I drive. Insurance companies have lots of data on the problems of not sleeping. So that's pretty much what I'm going to cover. We'll address the rest of it in question and answer.
Thank you so much, Dr. Altman. The model of that vagina is fabulous. If anyone has any questions for Dr. Altman after we're done, make sure you grab one of these pieces of paper, write her name on it, and ask the question, and we'll go through that at the end of the presentation. I would like to introduce you now to Tinrin Shu. Tinrin is a registered dietitian who specializes in cancer nutrition. She has a private consulting practice and works with patients at Diablo Valley Oncology, John Muir Health, and Altibate Summit. Tinrin.
Good morning. I have to move this down a little bit, otherwise I need a stool. Thank you so much for having me today. It's a great privilege. A lot of people ask, why, Tinrin, are you so passionate about nutrition or lifestyle change? I think physicians as well as patients are my best educator. Patients are the one that move me to learn more, and physicians are the one over the years, I think, because lack of data. We never really believed how important the nutrition lifestyle is until one day, about 15 years ago, I was contemplating, should I just forget about this whole thing, nutrition? Because data was so little. in regards to nutrition, lifestyle, and cancer. And here we're giving so many different treatments upon treatments, and nobody talks about nutrition, even though I was working with cancer at that time. And until one day, one of the doctor basically said one thing to a patient. He said, basically the whole thing started out, the lady was asking the doctor, what is my diagnosis, what is my prognosis, how long do I have to live? And the physician basically said, well, put it this way, you're sitting on this beast, and the beast is called cancer. And my job is to give you all the weapons I have, so that you can sit on this beast to keep the beast as down as long as possible. And when I'm out of the weapons, I will let you know, and walked out the door. And I see this lady, jaw was dropping, I'm standing in the room, and finally I walked up, I said, you know, basically doctor's saying is that there's a lot of options for you, and so don't count the time or the death time, and do not even give yourself a death sentence. Life goes on. So that whole scenario caused me to actually mulling over for about 3 months, because I was at a verge, say, forget about this nutrition, let's do something else. So after 3 months, and finally the picture came about. Basically, the person is sitting on this beast, no doubt, but the person has to be strong. The person has to be capable to hold a weapon and to keep the beast down. And my job is to make sure that person can live as strong as possible, as good as possible, to run with it. And so the beast will become non-significant. So over the past 10 years, more and more data came about, talking about, especially we have genomics right now. We start realizing that body weight, nutrition, lifestyle factors, as well as exercise, will greatly impact the DNA repair, will impact the way to cell differentiation, and will also impact inflammation, mutation, as well as cell arrest. So there's a lot of things that we're looking at. And clearly you have heard Dr. Spahn talking about breast cancer ladies are living much longer and has great quality life. So so whether you're during the treatment or after treatment, so always think of what can be incorporated into your lifestyle. But what I'm going to do is just, as time's sake, I'm just going through real quickly what are the evidence and what are the solid data out there. I think one of the most solid data is body weight. Okay. And the research basically talking about excessive body weight, absolutely the greatest risk factor in increasing not only medical conditions, but also cancers of many types, including breast cancer. And so this is stated fact. Obesity, so hopefully most of you will know how to measure your body weight by just going to Google or any search engine, find your BMI, body mass index. Okay. Anything beyond, if you find your body mass index greater than 30, that is considered as obesity. So with the research, we do know that obesity absolutely increased breast cancer risk. But we don't have adequate data in the past 30 years that how does obesity or the weight gain during treatment associated with the breast cancer related treatment, the weight gain, does that really impact recurrence and also death rate? And until about 2005, one of the studies basically indicating as BMI, as a woman gains 0.5, that BMI in unit, up to less than 2, that recurrence rate practically increased by 42%. When the BMI increased by greater than 2, and the recurrence and death rate practically increased by 50%. Okay, so this has to do not so much as obese in a sense, but also excessive weight gain. And we know that premenopausal women tend to gain greater weight, possibly has to do with a decreased metabolism, has to do with a menopausal issue, and as well as decreased physical activity, possibly a little higher food intake, but simply just by eating a little bit more, we tend to gain weight. So same thing as during the treatment time, but we do know that with the research and data is that premenopausal women seems to be gaining greater weight. Okay, so what is the take-home message? Is that if you have gained weight throughout your treatment, don't sweat it.
because treatment time is so stressful. But kind of keep in the back of your mind to try not to gain more than 12 pounds or 15 pounds. I tell my premenopausal women a cutoff point just about 12 pounds because we know that during perimenopausal time, most women tend to gain about 10 to 15 pounds during that 10-year period of time. So that's the gauge I'm using. And within the next year, try to slowly reduce your body weight. The highest weight gain I think I've seen that was good about almost 10 years ago or 8 years ago. This woman probably gained within about 8 months 50 pounds, okay? But she really took another year and a half to lose that 50 pounds. One of the best things she did was that she set up a goal. She joined the American Cancer Society's fashion show. So because of fashion show, she has to lose that weight. So she exercised, she ate right. So she lost that 50 pounds, and I haven't seen her recur at all. The life goes down for her, so bless her. And so keep your body weight to less than about 28, I would say. Because all the data point to anything doesn't mean that you have to be at a perfect body weight at BMI of a 20 or 22. But whole thing is that hopefully you'll bring the BMI down to less than 28. The other thing is also know your body mass or fat mass. Some of the women, their percent of body fat, basically body fat is estrogen driven source for postmenopausal women. Some of the postmenopausal women can carry that body fat as high as up to 51%, 52%. That's my own personal record I've seen. And hopefully you'll drive it down. A lot of times the physician asks me, Tim, what are you looking for? What is reasonable percent of body fat? I feel that if we can get it down to less than 28% again, about 27%, that would be great. But if you're approaching to 30%, so kind of pay attention to that. Okay, this has nothing to do with body weight per se, but it has to do with a person as thin as or little as 90 pounds or 100 pounds. They may carry same thing, 50% of body fat. So that's a huge amount. Okay, and second research that is very solid. Of course, Dr. Spahn alluded to exercise. Over the time, we know the recent data, 10 years, we have more and more data pointing to the exercise. Exercise, the benefit, not only decrease estrogen clearance, but may help you to absolute data, not even the word is, I believe was 2005. Same data showed that exercise, a lot of women say the more exercise I do, perhaps I get a greater benefit. But all the research pretty much point out to be between 3 hours to 5 hours per week give the greatest benefit of risk reduction in terms of disease recurrence and death associated breast cancer. Okay, and that rate as high as up to close to 50% again. Okay, and lastly, I don't have to spend too much time because Dr. Spahn mentioned it about alcohol. Alcohol truly is one of the risk factors right now we start realizing, because when I started collecting alcohol study was about mid-1990s. The data wasn't really conclusive, so I was told, Timon, just drop it, don't even talk about it. Okay. Until 1998, Harvard came out with very good research, involved more than 136,000 women with 10-year study with 3 countries. So that started to establish that alcohol research. I believe that was a pivotal study, was 1998's publication in JAMA. Subsequently, of course, the most recent one was British study of the $1 million study, which enrolled more than 1 million women and followed for how many years? I can't remember the data, 10 years, I believe, more than that. Basically what they found, that one woman or a woman drink 1 drink a day increased their breast cancer risk by 12%. Okay. And then subsequently, of course, we have the most December published Kaiser study, we call the LACE, Life After Cancer Epidemiology Study. This is Northern California Kaiser Permanente study. It involved close to 2,000 women. The result of the study was very similar to what Dr. Spahn had mentioned. When women, and most women, 90% of women drank red wine, which is great, drank wine. I don't believe the data differentiate red or white. But what they have noticed that greater than 6 grams of alcohol, which translate into half a drink, which is half a glass of wine, which is half of the 5 ounces, so which is maybe 2.5 ounces. That's not much, okay? 6 ounces, 6 grams alcohol, or half a jigger of hard liquor, or just half or 6 ounces beer. So basic, those are the 6 grams alcohol. We translate that out. Women who have greater than 6 grams of alcohol per day actually increase their disease recurrence by 42%. Okay, that was huge. So take-home message is that if you were to drink, I know American Cancer Society, National Cancer Institute have always established 1 alcohol drink per day is reasonable, because more the reason data pointed out, I personally, I pretty much advise my woman to limit to no more than 3 drinks per week, and hopefully spread it out. Okay, because we do know alcohol does impact. I know Dr. Altman said, let's save it all. Drink about 3 at a weekend party. And so you're just sweating it out in one time. But our perspective will be spread it out, because we do see that alcohol may impact estrogen metabolism. So that's one of the new thing. And the other risk factor, and I think not really the risk factor, what are we talking about? The beneficial in terms of low-fat diet or fruits and vegetables. Even though the data is not that clear, as I said, we're the genomic state, we cannot really lock people up, give them very set diet. I remember when I was college days, even early career days, we do all this nutrition program. Everybody cheats after 2 weeks, so we can never really perform. Okay, unless we lock you up as the rats. And so basically, is that with all the research, whether it's WIN study or the WHALE study, never really was very significant, but let's just talk about the WIN study that was closed and published about 2 years ago. WIN study basically have these women did a low-fat diet. Original design was about 15% of body fat. Okay. And high fruits and vegetable, nutrition counseling, intervention, the cooking class, and so on and so forth. Some of you may have involved that in that research. Basically, the end of the study was, this piece actually makes sense. But what surprised everybody was that ERPR negative women, in fact, had the greatest benefited from the low-fat diet. Disease recurrence, relative disease risk reduction as high as up to 42%. And for ERPR positive ladies, actually their benefit a little bit less, was only 20+%. So that was to everyone's surprise why the low-fat diet would benefit ERPR negative women. Okay, that's one piece of work to take home. And back to a little bit about exercise and also alcohol. I think the greatest impact is on ERPR positive, estrogen sensitive type of tumor. Women who benefit the most are, from the exercise are the estrogen positive related, as it was women who benefit the most or had highest risk are the hormones sensitive type of tumor. And so with the fruits and vegetables study, the other one really was disappointing was the WHALE study, Women Health Living and study, that was again looking at the breast cancer diagnosis after breast cancer, divided the low-fat diet, divided all those fruits and vegetables, gave them 5 servings of fruits and vegetable plus a 16-ounce vegetable juice. But I think the data is after about 7 years, nobody follows the same diet anymore anyway. So you can see the newspaper, low-fat, high fruits and vegetable has no influence on the breast cancer recurrence, right? And I think Dr. Strawn's laughing. But the subsequent analysis of the whole study was very interesting. Dr. Strawn also alluded to that earlier, was that high fruits and high vegetable diet plus exercise reduced breast cancer recurrence by 50%. So that again is sounding. We don't really know it's really because exercise or really is a good diet. But the flaw of that study is that at the end, the most both group, control group and intervention group, their fat has no difference. They're very, very close. So perhaps that makes a huge impact. Okay. And the last thing, I won't bore you because of time, is that a couple of things I think we need to look at for disease survival. Women do experience severe amount of joint pain, aches, and osteoporosis, so on and so forth. Exercise will help with heart protection, no doubt. But the other thing is that we're looking recently, I think all of you already know about the vitamin D impact on your bone health. Okay. And so up to about 2 years ago, Dr. Pam Goodwin, I believe that study came out of 2007 or 2008 from the ASCO. Basically, women mostly, we do realize that lower vitamin D level negatively impact the survivorship with breast cancer. So, and the reality is that close to 75% of women diagnosed with breast cancer, they are either vitamin D deficient, vitamin D insufficient, or just severely vitamin D deficient. And generally in the white population, I would say most of them, they fall in the category of insufficiency level. But if you're darker skin, if you're a black population or Filipinos, many of you can fall in the category of a severe deficiency. And data was established, good vitamin D level should be 32 and above. Okay, a lot of ladies ask me, what are we really looking for? And I think the good amount for each one to reach, it should be at least mid-40s, if not higher. Okay, so data pretty much about, I would personally, I'm pretty happy as once you're high 40s of the vitamin D level. What does the vitamin D actually do to you? Last year at the ASCO, I believe it was ASCO, there was one videotaping was that researcher was interviewed. What they found was that vitamin D, by giving higher dose vitamin D supplements, actually reduce that joint aches and pains and muscle pain. That's number one. Number two, recent data also showed, with a woman with a neuropathy and everything, actually vitamin D supplementation also reduces the risk of fall. Perhaps it has to do with the balancing, I'm not sure. But for bone health, we do know there's a piece of benefit for bone health. For cardiovascular health, we start realizing that by bringing the vitamin D level to an optimal level, there's also cardiovascular benefit. And with the diabetes research, we start realizing there's a better glucose control once the vitamin D level is up to par level. And of course, right now we also look at vitamin D has to do impact with the mood. People will be happier. I'm not saying so much happier, perhaps they have less bone pain and joint pain, I'm not sure. But with vitamin D, there's a psychological journal also indicating there's a tremendous benefit for emotional balance, mood balancing. So right now we're looking at all the vitamin D researches. There's tremendous benefit. I think most primary care, as endocrinologists, besides oncologists, are looking at is vitamin D level. So I would recommend all my breast cancer patients, as well as all my cancer patients in general, at least get a vitamin D level done so that we know how to appropriately supplement the vitamin D. All right. And other things I'll just leave to the question and answer session. Thank you.
Thank you so much, Tinrin. So right now, what we'd like to do is go ahead and have you pass the pink questionnaires forward. We're going to have some staff here that would be happy to collect those from you. So if you have some questions for Tinrin, Dr. Altman, or Dr. Saban, go ahead and pass those forward, and they'll go ahead and review them. But we have sure talked about a lot of different things, starting with what happens to survivors of breast cancer and various treatments, sexuality and menopausal issues, how to tame the beast while measuring your personal health. And now it's time to talk about a story of survivorship. Next, I would like to introduce to you Radhika Gupta. Radhika is a breast cancer survivor who has generously agreed to share her story with us today.
Good morning. Let me thank you all for being here. But let me start by thanking Dr. Saban for inviting me to speak today. I'm honored and flattered to be here and to share my story with all of you. Many of you in this audience have also traveled and still continue to travel the breast cancer road. And all of you have stories that are unique, interesting, and worth sharing in their own right. What follows is simply my story, my experience with breast cancer, and my journey, starting from that day in October 2006 up until today. Here's what happened. My daughter Sona, who is here, had just gone away to college. And while we missed her dreadfully, my husband Amar and I were getting ready to settle happily into our new life as empty nesters. I was 46 years old, and a few days after a completely clean and on-time mammogram, I found a lump in my left breast, very close to my underarm, which is probably why it was missed on mammography. I informed my doctor, and after he examined me, he sent me to have a needle biopsy. A couple days went by, and I was waiting to receive a call from his office telling me what the results of the biopsy were. This is when my wonderful friend Mary, who is here, reminded me that it was a Friday, and that unless I did something right away, I would have to go through the entire weekend not knowing my results. So Mary drove me to the facility where I had my mammogram, and there I was handed an envelope. I opened it to find that it said very clearly the word carcinoma. That was it. I knew that I had been shoved onto this path, and that like it or not, I would have to travel down it. I called my husband Amar right away because he's my rock, more supportive and loving than I deserve. And his immediate words, "It's okay, we'll get through it," became our mantra for the rest of my illness. His support is significant because I have already put Amar through one prior major and prolonged medical adventure that culminated in me having 9 hours of brain surgery. And now this, unrelated cancer diagnosis. And so you couldn't blame us for thinking that we had paid our medical dues already. All this was not quite what Amar had signed up for, but here he still is, and for that I feel very lucky. The next person I called was my sister Geeta, who lives on the East Coast near Washington, D.C. She's 4 years older than I am, and we have always been uncannily close. I told her, she cried, and then she reverted to her characteristic take charge, big sister manner, and she completely cleared her very busy professional calendar and planned to fly out to help me and my husband through the ordeal of my upcoming lumpectomy, radiation, and chemotherapy. I was grateful for her offer of support through what I had been told would be a difficult time, but most of all I was looking forward to spending time with her. Visions of all the things we would do while she was here in my home danced like sugar plums in my head. The chick flicks we would rent and watch late into the night, the dishes our mother had perfected that we would cook together in sisterly bliss, the endless chats, the list was long. But something else was on my mind. I could not ignore the steady thrum in the back of my head that told me that Geeta too needed to be certain that her recent clean mammogram was not that most artful of deceivers in medicine, the dreaded false negative. So at my insistence, she did a breast self-exam right away. And so it was that within days of my finding my lump, my sister Geeta also found a lump in her breast. A lump that was larger than mine and just as malignant. So I was the canary in the coal mine, but that was no comfort in the days of mind-numbing confusion that followed. I just could not believe that she now had breast cancer too. Her diagnosis was gratuitous, simply too much. How could it be that both she and I had forgotten to jump out of the way in time in this cosmic game of tag? I was very worried about her, but like the baby sister I am, I was mad at her too. How could she be so ill exactly when I needed her most? Hadn't our mother taught us how to take turns? Also, with every instinct in my body, I wanted to fly out to be with her during her surgery and chemotherapy. But I could not. And so it was that on opposite coasts and on an almost identical schedule, Geeta and I each had a lumpectomy, chemotherapy, and radiation, which deepened our already uncanny empathy for each other. People have always told me that I am a brave patient. but I'm not brave in the least when it comes to the people I love being unwell. I can tell you without the slightest trace of selflessness that I far prefer being ill and in pain myself. It pales in comparison to the pain and suffering of my loved ones. In fact, this is selfishness in its purest form. My next fear was how I would break the news to my father, who was 83 years old at the time. My mother, a physician, had died 3 years before, and so he had to now, all by himself, deal with the shock of both his daughters being seriously ill. I know he missed my mother and the way in which she would have guided us all calmly through this crisis, as she had through so many others. But my father, though very worried about his girls, handled the news with the courage and stoicism that is so characteristic about him. I reassured him by speaking to him every day of my illness, and I like to think that my upbeat attitude helped him. But telling my daughter Sona was the hardest thing I have ever done. Most of all because I felt like I was letting her down by being unwell. Here I was, a mother who adored her and would do anything to make her happy. And yet I was going to have to give her news that would inevitably make her sad. It just didn't seem fair, so I was racked with guilt over something that simply wasn't my fault. But Sona handled the news with such maturity and grace that I was reassured. It helped that I have always told her the whole truth about everything all her life, and that she trusts me completely. I answered all her questions truthfully, and so the consensus we came to was that some things I would face would be painful and or irritating, but that I would be fine once I was done with treatment. Despite this, let me end by saying that I am no Pollyanna who sees the good in every lousy card that I am dealt. It's true. I would much prefer never having had cancer in the first place. But for me, what has made this journey worthwhile is the wonderful doctors I have had along the way. For instance, though many of you may challenge me on this, I firmly believe that I am Dr. Tiffany Savant's favorite patient. So attentive, loving, and personal is her care. At every chemo infusion, I felt certain that I had the undivided attention of my nurses Tony and Mindy, and I will never forget their many kindnesses. Dr. Deborah Curlin is the most perfect combination of technical skill and human compassion that you could ever want in a surgeon. And Dr. Vince Masulo, my radiation oncologist, who is always so upbeat and reassuring that I looked forward to seeing him every time. So, although I do not like the cancer diagnosis that started me along this road, the journey has been a good one. Old friends came out of the woodwork, ties were renewed, and my daughter Sona, who is 21, and Geeta's daughter, my wonderful niece Naina, will now always be vigilant and prompt about checkups, and as we all know, early diagnosis is the key. Thank you very much.
Thank you so much, Monica. That was such a great story. So good. We have had such a great discussion so far, and now that we have heard from our panel and our breast cancer survivor, it is time to begin our question and answer session. We're going to begin by reading some of the Q&A cards that have been collected, so I think we'll just pass it over to the ladies and let you guys get started, okay?
Give us 1 sec.
So this guy walks into a bar and says, ouch. I can tell some jokes while you look through the cards. That would be easy. Yep, Dr. Altman, okay.
Is this working? So I have a few questions about antidepressants, and whether one antidepressant is more effective than another, whether Neuron's more effective. I put a little handout in your thing, and it lists the names, and forgive me, I put the brand names, because I'm not real good at bilingual, and I also can't spell the generics. You spell Benfluoxam. And so the names are listed there. Whether one is better than the other, you can't tell that in the studies. I mean, we really don't have head-to-head studies, and it doesn't matter. That's why there's 31 flavors of ice cream. Okay? I might like chocolate, you might like vanilla. You try one till you find out what works for you. Somebody asked about another one called Cymbalta, it's one of the newer ones. Cymbalta required higher than standard doses for hot flashes. So it's really kind of a trial and error. What's nice is just because one doesn't work for you, something else might. And it's nice the more options we get. And weird things, so where does all this come from? There's an oncology group in the Midwest, a guy named Dr. LaPronzi, and I swear, this is my image of what happens. A woman comes in to see him and says, you know what, doc, ever since I've been taking Celexa for my depression, my hot flashes are better. He goes, oh, cool, let's run it through a study. And then they do a study, and they give half the women the drug and half the women the other, and then they see what happens. And they do a neat thing where they ask women, so what do you think? With, you know, pros, cons, what's your overall, you know, would you recommend this? And that's, so we keep adding stuff. Who knows what, you know, the next one will be. But there is no particular right answer. Another question I had was, how do you know when it's menopause? Well, first of all, if you had your ovaries removed, that's it. You're done. Because it's really not menses pause, it's really dead ovary syndrome. Okay? The ovaries are done. Somebody asked if I had my ovaries and I don't have symptoms, will I? Nope. You had them, you've been through it, you're one of the blessed 10%. The official definition is we haven't had a period for a year. Or if your FSH level is above, and the gold standard I was taught was 40. The problem with measuring that level is it might be there for a while and then change. So it's really no period for a year.
I can take a couple of questions now. A lot. All these piles. Okay. So I think there's a great question that came up here, which I'm going to generalize a little bit. The question was, how does one know if hormonal therapy is responsive? And I think what the real root of that question is, how do I know that all these treatments I've just gone through that have made me feel not so great have worked? And I think that's a really important question. In most cases with early stage breast cancer, most cases, women are having their surgery first. So the cancer is being removed in the breast, potentially in the lymph nodes, and so when they start their either chemotherapy or hormonal therapy, they are at that moment, as far as we know, cancer-free. So we don't have any tumors in the body that we know are there and can measure. And this is generally, there are some women who actually have their chemotherapy first. But generally speaking, we're not treating something that we can see. And that can be difficult to get your head around. What we are treating is what we know to be microscopic disease. So we know that these cancer cells, the cancer tumors, have the ability to release cells before the tumor is removed. And these cells are swimming somewhere in the body, or they're hiding in an organ and we can't see them. So you have to take, from us, you have to take on faith that we are saying you need this treatment, even though you're sitting there cancer-free. And so there is no measure at the end of treatment for me to be able to say to you, this worked, good job, we're done, it's over. There's nothing like that, and that's really difficult. So what it comes down to is time. And so we know that as we move further away from a diagnosis and treatment of breast cancer, the further we are out in time, the less likely it is that the cancer is going to come back. So it's really in retrospect that we're able to say your treatment worked. We know that 80% of breast cancer recurrences occur in the first 2 to 3 years after diagnosis. So when a woman reaches that time point, that's their first milestone. And I say, congratulations, 80% of whatever risk you had is behind you, and we still have a little bit left, and at that point it's small. It's not gone, but it's much smaller. 5 years, another time frame that we're excited about. 10 years, fantastic, and we just keep going. So that's an important thing to recognize, and it's hard for women. You know, there are other cancers, and with advanced breast cancer, it's different, where there's a tumor in place, we're doing a scan, the tumor's this size, do another scan, it's smaller, it's working. We don't have that in most cases of adjuvant treatment. So that was one of the questions I had.
There are 3 questions in regards to vitamin D. One is, what is the difference between vitamin D1 or D3 or D2? The other one is, what is the proper dosage? And the third question, how important is a blood test for vitamin D? My doctor just recommended, just go ahead and take it, 2,000 units per day.
But to answer for the third question is that I do feel there is a great benefit doing the vitamin D level draw. What if a woman who walks in the door with only the vitamin D level of 11? I even have seen the vitamin D level as 7. 2,000 unit vitamin D a day will not bring your level up to 57 or even 47. It may take you many years. That's note one. Number two, sometimes if your vitamin D level is so low, many doctors will give you a prescription dose of 50,000 unit vitamin D. Very often I even have women besides 50,000 unit vitamin D once a week. I have daily other days take another 2,000 each day just to bring the level up. Generally we give about 3 months period of time to bring the vitamin D level. If we know the vitamin D level is that important, I tell my patients, I don't want you to take the slow boat to China method and take you 10 years to bring your vitamin D level up, because we don't know what is that impacting in terms of immune function or other conditions, medical conditions. So I would strongly recommend get a vitamin D level done, and so that a more appropriate dosage could be recommended. And why do we use vitamin? There are different forms, but reason 2 years, because there's so many data came out about vitamin D. So I would say all the over-the-counter vitamin D are in the D3 form, vitamin D3, okay, and which is much more bioavailable vitamin D. But the rule of thumb to take vitamin D, you have to take it after meal with some fats. Because vitamin D is a fat-soluble vitamin, so you cannot just say, I'm just taking with a glass of orange juice, or just take a glass of water and go with your life. You can't do that because you won't absorb it. Okay. And the last thing I think I would like to comment on is that, as I said, we're doing one of the genomes. Some women may not have a good receptors, so they may need a higher dose, because over the years I've seen some of the women may respond very well with just 2,000 unit vitamin D, maintain that at a very good level, but some of the women may need a 4,000, 5,000 on a regular basis. So in a sense, I generally say at least get it done, vitamin D as your baseline, know where you are at, bring it to the optimal level, and get another retest. That's basic.
The reason that vitamin D, by the way, is such a problem is that the main source in nature is the sun without sunblock, which I think has been made illegal in California. That's why we're all low. Your other alternatives, by the way, are daily ingestions of fatty fish, herring, sardines, and mackerel, in which case you will die of mercury poisoning. Hence, we're all vitamin D deficient. And the darker our skin, the more natural sunblock we have. If you're a strict vegan vegetarian, you need to know vitamin D3 is an animal source product, so you want D2. The prescription strength D that we use happens to be D2. I don't know why. Okay, a lot of this is tradition, by the way. It came from renal failure patients. I came to be using this with osteoporosis patients. So even if this doesn't pan out, that it's like the great savior for breast cancer, you need it for your bones, you need it for